Hello, I'm Donal McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Switzerland and I'm talking to Dr. Alexandre Gouveia. Alex, you've had a fascinating career. Let's take you back to the very beginning. What started your interest in medicine?
Hi, Donald. Thank you very much, and welcome to Switzerland. So actually, it's a big journey. I think it started really far away from Lausanne, Switzerland. It started in the Azores, so in the middle of the Atlantic. When I grew up as a little boy, I was always fascinated by uh, two general practitioners that changed my life. So my mother and my father are both GPs, and I grew up in a family with my two brothers, being always stunned by the way that they actually communicated, by the way that they worked in the rural area by taking care of patients, and all the stories that actually we listened back home then was really interesting. And actually, they motivated me to become a doctor. And I also connected a lot with their colleagues, with the GPs in the area. So this is, I think that it quite showed to me that there is a nice humanistic side in medicine, which is not only technical, but could be really in terms of connecting with people, understanding their lives, living their stories, and of course, helping them to get better and better. So I grew up as a little boy in Ponta Delgada, which is the main city in the group of islands of the Azores, in the Azorean archipel. In the Azores, we have 9 islands. One of the biggest one is São Miguel, and that's where I grew up until I was 17. And then I did my medical studies in Lisbon from 98 until 2004. And those my basic training was done in Lisbon. And afterwards, I did my postgraduate training as a GP in the north of Portugal, in the small town Viana do Castelo, with my wife. She's also a GP. And later on, in 2014, we decided to move to Switzerland, and that's where we are living since 10 years ago.
Well, let me bring you back to Portugal and medical school. Was family medicine part of your curriculum in medical school?
Yes, we had a chance to learn family medicine, not only on the theoretical principles and the basic foundations of primary care, but also with some rotations that we had in community medicine. And I had the chance to do 2 or 3 rotations during my undergraduate studies that really were quite interesting and confirmed my drive and my interest in primary care. So there were actually, I think, the undergraduate exposition of students in medical students in Portugal is quite important. We have quite an interesting history in primary care in Portugal, where there is an important reform that was done some many years ago, not the latest reform in 2006, but even in the 80s, in the 90s, there was a lot of innovations and developments that were done in the Portuguese primary care in terms also for the postgraduate studies, were a very consolidated and well-developed vocational training program. And this really, I think, created the foundations of the Portuguese primary care that we see nowadays, with some amazing results in terms of healthcare indicators and also satisfaction in the primary care health workforce, with some very interesting organization in terms of family health units and primary care teams that are nowadays the core unit of the success of the Portuguese national health system.
Now, you spent 5 years as a GP in Portugal, but you were part of a generation of Portuguese GPs who were very dynamic and very enthusiastic and very committed. Tell us about that.
I think we were a group of people that actually finished training in that period from 2000 to 2015. And we had really the chance of having a very important primary care leadership, or that were actually well, I'm not going to speak from different names, but of course, perhaps people just like Louis Pichko, that was really engaged in the Wonka development in terms of international primary care. Later on, we also have João Sequeira Carlos, who helped create the Vasco da Gama movement. And I think just to cite two of them, those are really leaders in primary care that were actually pushing forward a group of brilliant colleagues that actually were really interested in advancing primary care in Portugal in terms of clinical teaching, but also in the research fields. For example, Jaime Correia de Souza, who is actually a leader in this and research and development in primary care. Those are, for example, three people that I would like to say that actually they created a momentum in the beginning of the 2000 from 2000 to 2015 that actually could be, for example, the moment in which we reached a really interesting, I think, peak of the primary care development was the fact that the reform that was initiated in 2006, some 8 to 10 years later, it was quite consolidated in the beginning of 2010 until 2015-16. And then we have this new generation of GPs that were actually being trained in Portugal, assuming some different roles of leadership, for example, of primary care teams, and also in some specific regions, healthcare regions in Portugal, actually kept up the developments that were conducted in the previous years. And I think, for example, an interesting moment, and that's what I was going to mention also for our Wonka conference in 2014 in Lisbon, was this moment in that we said that we reached a certain peak of our development in terms of organization, in terms of leadership, in terms of training, in terms of research, and we still see this energy keeping on moving forward. And I think we will see this this year in September in 2025 with the World Wonka Conference that is going to happen this year in Lisbon.
Well, then, after this period in Portugal, you've moved to Switzerland. That's a very interesting move and really promoted your academic career. Tell us more about that.
So actually, that was one of the major goals in that period of my career. I was working as a GP in a primary care team. I was really happy by the work that I had as a frontline primary care worker. We were a big team of 8 GPs, 8 family nurses, and 6 clinical secretaries. I was actually working with my wife on the same practice, just nearby where we lived. And I was also working with Jaime Correia de Souza at the University Department of Community Health in Braga, in Minho. And I was in a situation in my life where there was I had some clinical responsibilities, some academic responsibilities. I was also working at the executive board of the Portuguese Society of Family Medicine, APMGF. And I just decided to reorient things a little bit because I was actually having a lot of difficulty to conduct research in primary care. I was really enthusiastic about it, but initiating a PhD at the moment was not actually feasible in terms of work-life balance and all the different roles that I assumed at that moment. And I just said, we discussed a lot with my wife, and she did 2 years of her undergraduate studies in medicine in Paris. She was quite fluent in French. We do have also some family in Paris, and we decided to just change our perspectives in terms of professional development in Portugal. I think there was also an impact of what were the difficulties back then that the Portuguese NHS was facing after the 2012 economic crisis. So there was a little bit of a negative feeling of what could be the perspectives for the following years. And then we decided, let's try to reorient a little bit things. So my main driver was actually to reinforce my academic skills and knowledge, and to for my wife was actually to acquire more expertise in geriatrics. So she actually initiated at the moment postgraduate studies in geriatrics, and So she actually reoriented a little bit her career from general practice to geriatrics, and I just reinforced for academic primary care. And I had really the opportunity to come to the University Department of Primary Care in Lausanne, and since then I'm still working here at the institution.
And you had the opportunity then to do your doctorate, and that was a very interesting topic. Tell us about that.
Yes. So first of all, I had to actually do my training in general internal medicine in Switzerland, because this is not recognized, since we are Eurodocs, primary care physicians and general practitioners in Europe are not automatically recognized and do not see their postgraduate training automatically recognized here in Switzerland, because internal medicine and general practice are combined in a single specialty that has 5 full-year training. So I had to reconduct between 2014 until 2019 my general internal medicine specialty training. And after that period, I initiated my doctorate, which was focused in quality of care and potentially avoidable hospitalizations. And that was the study that I conducted. Some of the publications have been finished last year, but it was mostly ambulatory care sensitive conditions that were analyzed in the 20-year period from 1998 until 2018 in Switzerland for four ambulatory care sensitive conditions: asthma, COPD, diabetes, and heart failure. And we found out that unfortunately these conditions have been increasing with an important cost to the healthcare system, which reflects a little bit eventually the lack of training, skills, and also pathways that exists in primary care to provide better and more care to these chronic conditions in terms of avoiding also this hospitalizations at the end of the healthcare chain.
Well, you're still very interested in the international component, and you're doing some work at Harvard. Tell us about your Harvard involvement.
Yes, thank you. So actually, when I was finishing my doctorate, I said, what would be the next step? And since I'm really interested in medical education, and for our institution, in one of the missions of our department is actually to train family medicine residents. We have a big team of 50 family medicine residents that are supervised by 20 chief residents and senior physicians. So we wanted to go a little bit further in terms of the educational methods, and also to understand what will be the solutions that we should provide to the current challenges that medical education, and specifically nowadays family medicine, faces. So there is this opportunity to start a part-time master's in medical science program at the Harvard University, at Harvard Medical School, and I started in 2022. So I'm currently now conducting my thesis work, which will be focused in artificial intelligence and the management of uncertainty. And I think if everything goes as predicted, I will finish my master's next year in 2026.
Well, I'd like to come back to the artificial intelligence, but you also published an editorial in the Swiss Medical Review in the autumn, looking at the data behind general practice and general practice workforce, because there are challenges in Switzerland. Tell us about that.
Yes, the challenges, I think they are European, they are really worldwide, but for the Swiss context, what we see is that actually there is I think two of the main challenges are actually the lack of primary care practitioners that we are going to face in the next 5, 10, 15 years. So we do need to increase the number of trainees, the number of primary care practitioners, the number of GPs that are working in our country. And this is not, I think the solutions is not just increasing the number of primary care training units, but it's also to see how can actually we can correspond a little bit in terms of what do primary care practitioners actually perform in their daily lives. So there is this interconnection with the second challenge, which is really the content and the objectives of the primary care activity. And I think so in terms of solutions to the redefinition of what is the core business of the primary care activity and the activity of general practice will be related to interprofessionality, to task delegation, to, for example, working with other healthcare professionals like pharmacists, like primary care nurses, to also physician assistants, eventually integrating the future healthcare workforce, such as medical students and also the trainees working side by side with general practitioners. So really redesigning the primary care network and the primary care work field in terms of trying to make it more adaptive, more dynamic, and to make it more flexible, because we do see that the needs of the patients really they shift quite quickly. And sometimes I think that the old-fashioned model of a single-owned primary care practice will not correspond to the future, to the current and future needs. So primary care teams, interprofessionality, task delegation, this integrating also, of course, communication information technologies are really the next challenges that we need to also know a little bit more, to integrate it already in what we do nowadays, and then to make it able to teach and learn to the future general practitioners.
Bringing in this primary care team and medical home, it really is going to be a big challenge because it'll require a major evolution in Swiss family medicine, because it's quite different. You have hospital-based family medicine, you have small individual practices. How do you see that changing?
I think diversity is an opportunity. Of course, it's also a challenge. So we do need all the stakeholders, policymakers, decision makers to work together, and to try to exchange more and more so that we can find solutions that are adaptable and are evolutive. So we really do need to reinforce communication and collaboration to really provide solutions that are locally adapted, and of course guided by the best evidence that exists internationally. Switzerland, although we do have a lot of innovation in the healthcare system, we do have a lot of, I think, resources. It's a very expensive healthcare system, but this is, of course, mostly it has been in the last years, I think, with a certain risk, I can assume, it has been a lot of orientation that has been given, and a lot of financing also to the hospital specialties. And we do see that the majority of the healthcare is provided in primary care, but in terms of financing of the system, of course, we do need improvement in terms of that balance between what is the money that is given to secondary care in terms of the money that is provided to primary care. So, for example, payment to doctors is, of course, one of the barriers. And this is also an element that has been worked by our national organizations in terms of reinforcing the image and in terms of increasing the value of what is given to the primary care practitioners in terms of the healthcare functioning, the healthcare system functions, the way it functions. So I think this is of course, it's a challenge, but we do need to make all the actors to keep communicating and to reinforce the discussion, because otherwise, if we don't change the way that the system is organized, of course, it's not going to be attractive for the next generation. But the fact that we have, of course, a very bottom-up way of organizing the system with a lot of liberal opportunities. For example, we don't have, in terms of the creation of primary care teams and practices, there is a certain liberty for GPs to work where they want. So it's not state-owned or state organized. The regions, the healthcare authorities, they provide a certain type of validation in terms of your competencies and skills to become a GP working in the ambulatory care. But actually, where do you want to work, or where are you going to open your practice? This is not completely settled. So we do need, in terms of public health, more of this type of planning, to say that actually we will probably be less liberal in terms of opportunities that are given to GPs to work where they want, So it's mostly market driven. If there is a lot of competition, of course, GPs will not work on that place. But we should impose, perhaps in terms of public health perspectives, in terms of accessibility to primary care, we should perhaps impose a certain type of areas that lack GPs and could be eventually better reimbursed for practitioners that work in those primary care deprived areas. That could be, for example, one of the specific policies and strategies that can be adopted, accepting the diversity and richness that we have in the healthcare workforce panorama.
So marrying your two interests of the workforce and the future of the team with your expertise in artificial intelligence, which some people think is going to solve all those problems. Finally, give us a vision of where you think artificial intelligence fits in the future of primary care.
Well, I think it's going to make primary care evolve, but it's not going to revolutionize completely healthcare as some propose or advocate. What I think will happen is, as we saw with internet, doctors that use internet will replace doctors that don't use internet, and doctors that use artificial intelligence or teams that use artificial intelligence will eventually replace primary care professionals that don't use it, because it's going to be in terms of the perhaps in terms of the primary care services that are provided, in terms of also accessibility, continuity, and also the quality of the service provided, there is going to be a lot of help that's going to be given by artificial intelligence algorithms and electronic health records that integrate some specific algorithms that, of course, need to be calibrated, need to be adapted, need to be validated. I think they will be really useful in terms of time allocation, for example, to see patients versus administrative tasks that are going to be done by doctors. So doctors will be facing these new tools, and they will have to choose whether they would use tools with AI or not. And I think for the benefit of using time more efficiently and eventually diminishing cost also, they will be actually pushed forward to the AI integrated technologies. Because, and I see nowadays, if actually we integrate smoothly and in an intelligent way artificial intelligence in our clinical reasoning, in our administrative tasks, of course, respecting safety and healthcare data protection, we can actually improve the use of our time and make eventually a better use of our skills for complex situations, for difficult relationships, for in terms of applying our expertise in situations which we are not replaceable.
It's been a fascinating journey from the pure family medicine and very much family medicine that you started off and were brought up with to this vision of artificial intelligence in the future. Thank you very much for talking to us today. It's been wonderful, and thank you very much for sharing so much of your life and career.
Thank you, Donald.
Thank you.
Thank you for the opportunity.